El día de hoy empezaremos con el Dr. Donald Hood. El Dr. Donald Hood es profesor de Ciencias Oftálmicas en la Universidad de Columbia. Es profesor Bennett de Física en la Universidad de Columbia y ha sido hasta hace poco editor en jefe de la revista IOBS, que es la revista de Arrow. Así que, sin más, dejamos al profesor Donald Hood con ustedes y de nada, muchas gracias por asistir. Espero que sea una charla exitosa. So, Don, thank you for being here. The podium is yours.
So what I'm going to do is I'm going to tell you about a simplified method for diagnosing glaucoma with only OCT. And my financial disclosures, since you're here and eating lunch, you can imagine that I have grants and equipment from TopCon. Can you hear me in the back of the room? Good, okay. So let me start with some basics, just so that we're using the same terms. So to understand the patterns of glaucomatous damage, you have to keep the following things in mind. First, problem? Oh, too loud. I'm sorry. First, glaucoma kills ganglion cells in their axons. So because of that, you have to understand the pattern that these axons, sometimes called retinal nerve fibers, take as they travel from cell bodies to the disc. So you've all seen schematics such as these. This is meant to capture the notion that the ganglion cells on the disc or nasal side send their axons more or less straight in to the disc, while those on the temporal side arc around and avoid the fovea. This is only a small part of the back of the eye. As you probably know, you're only looking at about that much of the back of the eye. So you've got axons coming from other areas, and they bunch up here in this region here, and that region is particularly vulnerable to glaucomatous damage. Same thing is happening up here. I'm not going to draw them all in, but again, you've got another region that's particularly vulnerable to glaucomatous damage. The next point you have to keep in mind is that damage occurs in and at the disc. So damage is occurring either at the edge here or more likely in the disc, which means that you're going to get retrograde degeneration that's going to be very characteristic. It's going to cause characteristic arcuate patterns. So for example, damage anywhere in this yellow region will give you an arcuate kind of defect here. Same thing here. These are just examples. Any place in here, arcuate. And here's a local one. Here's another example. Okay, so what you're going to be looking for on OCT is characteristic patterns of glaucomatous damage. You're not going to be looking at the pie charts. This may come as a shock to some of you. You do not have a pie chart in the back of your eye that changes colors. What you have is damage that's going to be arcuate in nature. Okay, so I think you all know about OCT. It's a non-invasive technique. It's like ultrasound, except it uses light, so it has better resolution. Here's a scan, a single line scan through the back of the eye. This is where the ganglion cells sit, and their axons travel and then go down the optic nerve. This is the retinal ganglion cell plus in a plexiform layer. I'll just be calling it the ganglion cell layer. And this is the retinal nerve fiber layer made up of the fibers, that is the axons from the ganglion cells. Yes? Okay, so let's get right to it. So here's the simplified method. We call it the Columbia University method because it actually came out of a series of meetings that Jeff Liebman organized with my help. Jeff is vice chair of ophthalmology at Columbia, and he's also head of the glaucoma division. So these two papers describe the technique. All right, the technique makes use of what TopCon calls the Hood report. It's a one-page report that for clinicians to quickly diagnose and understand the glaucomatous damage. And it's actually based on an article that a student and I wrote in 2014. So we're going to get rid of these temporarily. This is the information we're going to be using in the simplified technique. So the method involves 3 questions for the clinician to answer, and the first 2 questions involve the retinal nerve fiber layer and ganglion cell probability, sometimes called deviation maps. So it's essential that you understand what those maps are. Okay, so these are the probability, or sometimes called deviation maps. So let's start with the retinal nerve fiber layer map. Here, this cube scan, which is a wide field scan that Topcon uses, you have many of these. This is what one looks like. This is the retinal nerve fiber layer. This is a pseudo-color thickness map. So this is the retinal nerve fiber layer thickness map. Red is good, it's thick. Blue is bad, it's thin, right? To get the deviation map, the software compares this point by point to a normative database. And you get this probability map, right? It is in field view, which I'll define in a moment. Now, green is good, within normal limits. Yellow would be about 5%, red is 1%, dark red would be 0.1%, right? We take this map here, and it's flipped along the horizontal for a reason I'll tell you about in a moment. But first, let's talk about the ganglion cell plot. So for the ganglion cell thickness map, we now use this layer here. Once again, and we're going to be looking at the central 20 degrees here. This is the thickness map for the ganglion cells, right? Once again, dark red is thick, that's good. Dark blue is thin. It gets turned into a probability map, right? And again, green is healthy, yellow is cautious, red is abnormal. And this is flipped along the horizontal so that this is the superior visual field but inferior retina. So red is bad here, red is good here. So this defect here corresponds to this. I apologize for that, but it's not my fault. This is the convention of all the companies. When you look at a thickness map, red is good. When you look at the probability or deviation map, red is bad. All right, so why do we flip along the horizontal? The reason for it is it makes it easy for you to compare the OCT damage to the visual field damage. So here's a visual field for this patient taken about the same time. You can now circle this and then circle the equivalent points, which are the big points here, and you can see the correspondence. Likewise, with the 10-2, you can circle the points here, and you can circle here, you can see the correspondence. So we did it. I don't know if it was the best decision, but that's why we did it that way. All right, now I want to emphasize, I'm not going to be talking about visual fields today. You'll hear some about that in the next lecture, because I'm going to just tell you about a method for diagnosing and understanding glaucoma based upon only the OCT. All right, so it involves 3 questions. The first question involves the retinal nerve fiber layer probability map, like so. All right, so here's the question that for the clinician to answer. Is there an arcuate-like abnormal region on the retinal nerve fiber layer probability map that's associated with the temporal half of the disc? All right, so what do we mean by that? Okay, so here's the temporal half of the disc, right? And now I'm going to show you some data from 2 recent publications. This had a range of patients with different defects. It had 18 patients that had advanced glaucoma, and that's based on the 24-2 worse than -12 dB. And you can see if you take these and superimpose them, there are the arcuates. You don't need a very fancy test to pick up advanced glaucoma. By the way, all these eyes are shown in right eye orientation. Here are 12 moderate glaucomas, visual fields between -6 dB and -12 dB. Let's just blow one up, and again, you can see the arcuate-like damage. And now the more challenging cases. Here are early glaucoma, meaning the 24-2 was better than -6, but based on fields and photos and so on, the diagnosis was glaucoma. And again, for many of these, you can see the very clear arcuate damage. Okay, now here's an important point that has to do with how you answer the first question. If you look at even the most subtle of defects, they have some red near the disc. So we found that that's a trick we can use. You're going to say no to question 1 if there's no red near the disc. If there's an so here are 8 examples of no. Let's blow them up. In any one of these, you're done. It's not glaucoma. So in many cases, your healthy controls will look like this. Sometimes you might have a red spot in the center here, and I can tell you why later. Sometimes there are artifacts here. Sometimes there are artifacts there. Sometimes there are partial arcuates. These are almost always healthy controls, and you don't have to worry about it. Okay, so here's an example. Let's take an example. Patient comes in. That's what the probability map looks like. You're essentially done. It's no. Now, it's always good to look at the rest of the report, and especially the circumpapillary image. You know, so don't get misled by it, but because you've already have a diagnosis, but you look at this and you feel confident. Look how pudgy and healthy that looks like. Okay, here's another one. Forget this. The answer is no. Forget that little hint thing. That's almost guaranteed to be an artifact. You're done. It's not glaucoma. Now, if you look at the rest of the report, not only will you see this is healthy, but you'll see that this is shifted over compared to the norms, which is what's giving you this artifact. But you don't have to know that. This is all you need to know initially. All right. So in this article, in this publication recently that describes this technique, none of our patients had no to question 1, and 92% of the healthy controls did. And I'll tell you about the other 8% in a few moments. Okay, what's the rule for yes? Because remember, question 1, you can say no, you can say yes, or you can say uncertain. So what's the rule for yes? So you're going to say yes if there's an arcuate of red and yellow that extends beyond the vertical midline. So what does that mean? Well, this is the vertical midline, this black line. All of these have, some of them more subtle than others, all of these have an arcuate looking defect that extends beyond the midline, right? This rule excludes almost nearly all arcuate-like artifacts, so-called dreaded red disease, if you know the term, right? So what do we mean by an arcuate-like artifact? These are all healthy eyes. These healthy eyes, in fact, are part of the normative database in the machine, right? Yet they have these red defects that have to do with just anatomical, normal anatomical differences. They'll be, it's about 4%. If you have high myopes in your practice, it'll be higher. It could be as much as 10% or so, right? So this occurs in healthy eyes. But notice they don't cross the midline. And if you ask me later, I can tell you why that's true. Okay? Again, these are healthy eyes. All right. However, glaucomatous artifacts, often, not always, because you could have very early damage, cross the midline, right? Okay? All right, so arcuates that cross the midline are likely due to optic neuropathy. All right, so let's just apply the yes rule. So all of these are yes, right? Now, although you can be pretty confident you have optic neuropathy, to be really, really confident, you want to answer question 2. So what's question 2? Question 2 now concerns the ganglion cell probability map. You might have guessed that since there are 2 probability maps and 2 questions here. Okay, so let's blow that up. All right, so what are we looking for? If you say yes to the first question, so you've got an arcuate that crosses the midline. Now you're going to look at the probability map, right? And you're going to ask whether there's a topographical, meaning spatially, corresponding region. All right, so what do I mean by that? What I mean by that is the damage is in the same arcuate region. Remember the arcuate patterns. So here's the ganglion cell map, here's the retinal nerve fiber layer map. If you were to put them on top of each other, it's all part of the same region. Now you don't have to do that, you can just do that by eye because these circles are the same on both maps. All right, so let's apply that. So these are all yes. What about question 2? Well, all of these are yes. You can see nice topographical correspondence. These are either no or ambiguous. And again, the secret to this method is when in doubt, say uncertain because you'll get another chance. Okay, so let's take the yeses temporarily. If it's yes, you have optic neuropathy consistent with glaucoma. Now the reason I'm being careful is because I'm talking to clinicians and you know that this isn't necessarily glaucoma and you want to do a clinical exam and look at the disc to rule out ION and superior segmental hyperplasia and those other uninteresting, at least the glaucoma specialists, optic neuropathies. It also means that you have macular damage and you've got damage that's getting close to fixation. So let's just look at some examples. You look at this, so the answer is yes, it crosses the midline. You now go to question 2. Wow, look at that. That's clearly corresponding, right? You're done. This is optic neuropathy consistent with glaucoma. You're done. Now, make use of the rest of the report because you can learn other things, but you don't need it, right? It's always good to look at the B scan. There's the damage. You can actually see the damage on the B scan. There it is, blown up. All right, here's another example. Crosses the midline, you say yes. And once again, you look at this, and you can see that this is all part of the same arcuate, right? It's optic neuropathy consistent with glaucoma. You look at the B scan again, and you can actually see where the local damage is. Okay, now here's the good news. With only these 2 questions, you can as long as you've got a decent scan, 70 to 90% of your patients will be answered by those 2 questions. 90+% or so if you have many healthy controls, and closer to 70 if you have a lot of early glaucoma. Okay, so here's an example. For example, almost all moderate and advanced glaucoma follow this yes rule. Over 2/3 of the early glaucoma follow it, and I already told you about 92%. Okay, what about the other eyes? So we've taken care of 70 to 90%. What about the other eyes? Well, the other eyes would be uncertain to question 1, and I'll remind you, uncertain to question 1 means I don't know if it doesn't seem to follow I'm not sure it follows the yes, I'm not sure it follows the no, so I'm going to say uncertain, okay? Or you might have said yes here, but uncertain there, okay? These 2 routes, you need more information. And that more information is going to come from the rest of the report. You don't have to yet run to visual fields yet for more information. That can come later. But at this point, you're going to use the rest of the report. After you're done with looking at the rest of the report, you're going to be able to have the eyes as yes, no, and a few. So you can think about this as another way to decrease the number of suspects in your practice. Okay, so what's question 3? Is there a confirmatory evidence? Is there evidence consistent with a retinal nerve fiber layer defect in the rest of the report? So what we're looking for, or I guess I should say, what do I mean by confirmatory topographic or spatial evidence? I'm going to illustrate, this is a key part. I'm going to illustrate that by taking this example that we knew was yes, but I'm going to look at the rest of the report. Is that clear? Okay. So we're going to mean 2 things. The first thing is the same physical points should agree. If you have artifacts, it won't necessarily be the case, but the same physical points should agree. So here's the temporal half of the disc. In my report, this is equivalent here. This is presented as an end-stin, so the temporal region's in the center here, right? So this black arcuate is this right here, right? That means this location here is identical to that location there. And that location there is identical to this dip. Same location, you can see it there. And there it is on here, and there it is back there. So the ends of those yellow or orange arrows are all the same physical location, and if this is really glaucoma, they should agree. Okay, same thing here. This region here is the same as this region here, is the same as this region here, and this region here. Once again, everything agrees. Everything agrees. I think that's one of the messages of the next talk too. Everything should agree. All right, they should also agree with an arcuate region. So let's go back to this. This is with the arcuate examples I gave, and here's what it would be on the left eye. And so this region here is the same as this region over here. So let's flip this so that this is in field view, and let's superimpose it here. So what you're looking for here is an arcuate region that is damage is caused by what's happening right there, right? And so here it is here, right? This eye undoubtedly started out life something like this. Over time, it went down to here and created all of these other aspects. Okay, so let's take an example of where you need question 3. Yes to question 1, no to question 2, so yes and no or uncertain. So now we're going to take a look at this. Okay, all right, so you say yes here because this crosses the midline. You come here, you might be tempted to say yes here, but uncertain's your friend. You don't want to be misled by little tiny dots, okay? So now we're going to look at the rest of the report, and we'll go through a checklist. We'll look at the ganglion cell thickness, retinal nerve fiber layer thickness. Well, you don't have to get very far, do you? Look at that. Someone's taken a bite out of that donut. That's your ganglion cell layer. So this defect here is what this was hinted at, right? And it's consistent with that. So you're done. This is optic neuropathy consistent with glaucoma. And you can go through the checklist. This point here corresponds to that point there, right? There's your damage, corresponds to this, corresponds to that, and back to that. Same thing, same arcuate. You've got damage in that same region here, so it should be within this arcuate. And here it is over here it is down there. And again, this eye started out like this and then progressed to that. All right, so that's an example of yes, uncertain, and then yes, right? All right, so let's consider the last route here now. This is actually more common. It's more common to have an uncertain route where you have to look Okay. It comes in 2 forms, but I'll just tell you about the most common form. This is the form that people often call red disease, and those are the arcuate-like defects that do not cross the midline. So here are 2 eyes. This eye I can tell you is a healthy control. This eye I can tell you is early glaucoma because we have lots of other information on it, right? How do we tell the difference between these using this simplified method? Okay. Well, let's take this one first. So here it is. This doesn't cross the midline, so I'm going to say uncertain, because I'm really not sure, to tell you the truth, looking at that. All right? I now uncover this. By now you can probably see, you don't have to get any further than this map here to see that you have, if you can actually superimpose that if you want, you can see that this is a continuous defect, and you're done. You have optic neuropathy consistent with glaucoma, right? So the thickness map, this missing part here is what creates that red region, right? So that's yes, right? You're done. However, teach yourself more about what's happening here by taking a look at the whole report, because really this method is a sneaky way to get you to look at the whole report. So again, this region here is the same as that region there. There's the dip that's associated with it. There's the thinning on the retinal nerve fiber layer, and then back to there. Same arcuate. Once again, we have got an arcuate up here. This is a very, very common place for early glaucoma. Arcuate here, and this eye started out life like that. All right. Last example, let's take a look at the healthy control here, eye, right? Again, uncertain because it doesn't cross the midline. You go to the whole report, you uncover the rest of it, you go to the ganglion cell probability map. I don't see anything that's consistent with that. You come over here, there should be nothing's consistent with it. You take a look at the whole region here, and you see how healthy this looks, right? Here and here. This location actually is here, and now you're getting a hint of what's going on. What's going on is this is just a healthy eye in which this is tilted, this is tilted a little bit more than usual. So this region here is this region here, is that region there. So this is where the peak is in this healthy eye. This is where the peak is in the normative control. And since the peak in the healthy eye is more temporal, you're getting this arcuate. And this is what happens with high myopia, because with high myopia, these arcuates tend to be more in this direction here. These defects, normal peaks tend to be more temporal, and you get these red regions in your high myopes. Okay, so this is an example of this route here. Okay, so if you want to read more about this, these articles describe this technique. If you go to my website, and you can always email me, and I can give you the information. Here's the actual website. I have a lecture that we did recently that has a lot of examples in it that's similar to what this lecture is here. Thank you very much. You may want to hold this. Oh, yeah. Otherwise, it's going to sneak back there.
Well, thank you, Don. That was a great lecture as usual. Now we'll have Dr. Augusto Paranhos with us. You all know Augusto. Augusto is a professor of the University of Sao Paulo, a former president of the glaucoma chapter from the PAAO. And Augusto, thank you very much for being here.
Thank you very much. Well, we usually to see when you have a rock star, you have a local band to start the show. Today was the opposite. He is the rock star, and I'm really proud to be together with him in this lecture today. His lecture was about how to dissect the OCT, how to see everything that it can give you. I'm really upset when you see an ophthalmologist looking for the printed report of every OCT and not taking advance of every information that it can give you, and also how easy it is to make a mistake if you do not look properly the exam. That's, I think, was one of the most important things that Professor Don Hood was teaching us today. We are talking about something that it was his idea, taken from radiologists, the concept of region of interest. If you have a damage, for example, if you're suspecting for a lung damage, tumor, or a brain tumor, you have to concentrate all the effort to see what's happening in this area, if it's progressing or not. And it's the same when you're looking for a visual field or an OCT. Why is that? Because 80% of the progression would occur where damage is already on place. And this is important when you're working with suspicious patient, because you have this area that Professor Don Hood is explaining very well. Is it glaucoma? Is not glaucoma? So you have to look in every detail of this specific area, mainly the segmentation if it was already done, and also if it makes sense. If the area is in a place that you usually see a glaucoma damage, and if you're sure about the damage, pay attention on this specific place, because 80% of the progression will happen in this place. And remember, for the visual field, when you're looking out of the macula or working only with 24-2, you have only 6 stimulus every 6 degrees. So it's far one from another, and something could happen between these stimulus that you could miss if you just evaluate progression with visual field, or if you don't believe in progression on OCT because the visual field is stable. We are doing this since we have slides of retinography. This is a local defect that is very clear, and every patient that has a temporal inferior defect, you should do a very careful evaluation of the macula. And now you can see here that the damage was progressing, and it happens where the damage was already present. So this is a concept that you have to have in mind. This is one of his papers on region of interest in evaluation and how to improve the evaluation of OCT with this concept. And this is something that I really like to show. This is a perimetry in area of interest. When you know, for example, this visual field, this red sign to show that the 24-2 was normal. If you look for the unfaced OCT, there's a clear damage there, but it's a small one. If you work only with pizza charge, as Professor Don was telling, you're going to miss this because it just lose by the mean of this area. So it would be probably normal in the nerve fiber layer pizza map. But if you know that the damage is there and do a specific visual field, high density visual field where the damage is, it's clear that there's a defect there. And this is the same thing that Professor Hood have done in this paper. Again, if you look, the nerve fiber layer defect close to the optic nerve is very thin. And if you look only for the pizza charge, you can miss this. And if it's really thin, the segmentation could be not a good one, and you're going to miss it, as he was presenting this paper here. But if you look for the whole picture, actually the expression is very good. The whole picture, the wide picture, you're going to find the damage. If you start working with unfaced image, and you see, and if you perform a high density visual field in this area, something that you're going to miss in the normal visual field, for sure going to find in high density visual field, so it makes sense. I'm going to show you some examples of progression using the token OCT, and telling that what Professor Don Hood was showing us is not just something for research. It's something that you can use in your clinical practice. For example, this patient here, I'm telling you that there's a progression going on. I think that the resolution of the presentation is not so good, so you have to believe me, there's a progression going on the right eye. Now you can see here a local defect that's getting worse. And the visual field is also showing that it's getting worse. The cluster analysis, something that I like in the octopus, is showing that it's getting worse. So the visual field is telling that something is happening there. It's a normal rotation glaucoma. The patient is progressing with 10 millimeters of mercury. So we have to be sure that something really happening, because you have to do sometimes a surgery with a patient with 10 millimeters of mercury. You have to be sure that's a real progression. And you have here, it's a progression also the 10-2. And now the OCT. Again, it has to make sense. We are looking for the right eye, the nerve fiber layer here, inferior temporally. See the map here and how it had changed. And again, if you're looking for a trend analysis, that everything is flat, but the region of interest is getting worse, it probably is a real progression. But you have to look in the place and see if everything is okay, the segmentation is okay. So you have to dissect the the OCT to see if it's really a progression or not. And there's something that I like in the OCT, the top-down OCT, is the differential map. We are looking for a damage where? In the inferior temporal area, because the damage is already there. So if you see the difference between the baseline and the image now, and the difference map showing a defect with the shape that we usually see in glaucoma, it probably is a real progression. And if you do that with a different scans, it's also important because you're doing more than one scan telling the same thing. So again, it makes sense, it's a real progression. And we are able to see that also in ANFAS image that you can see from 2020 to 2023. The damage is progressing for sure. This patient has underwent trabeculectomy and hope that it would stop because now the pressure is really down and not fluctuating. See here before and after. You can see that just looking for the print image. You have to work with the machine. It's something that I really recommend everybody that has an OCT in his clinic, don't just receive the printout. Go down to the machine, spend some time, and sometimes you have to do that without in your office hour. I used to tell the patients, you know, everything seems okay, but I'll do a more detailed analysis afterwards, so if I can find anything different, I'll call you back. It's better doing that, drinking coffee, having time, so you can find some important information that you might miss if you look for every patient for every time 10 minutes. This is a very interesting case, a case of 48 years old, glaucoma suspect by the aspect of the optic nerve with familiar history of glaucoma and the use in the past of steroids. It's a high myopic patient, although the visual field does not like a high myopic retina. And this is the retina that we can see. Something that I also like for the Topcon is for every scan that I have a retinography. So sometimes you just miss hemorrhage. And remember that hemorrhage is 3 times easy to find in the retinography comparing to a glaucoma specialist using the lens looking for hemorrhage. So take pictures. Take pictures is something very important. And for the Topcon OCT, for every scan you have a retinography. The 24-2 was normal, and the 10-2 was also normal. We can discuss what's normal in this visual field, that we're not doing that now, but if it's the definition of normal, just 1 point, it's normal. And then looking for the red free is also something that the Topcon OCT give us is the red free. Although if everybody's looking now because there is also a sign, a green sign there with a question mark. Is there a local defect or not? But if you look for the ANFAS OCT, the Dunhood predictive analysis is showing a small defect that is very likely to be a real defect. And again, all the exams are normal. It's a glaucoma suspect because the pressure was not that high and has a history of steroids. It could be a real defect but not a progression, so you just wait and see if something had changed. I always tell the patient that when it's a glaucoma suspect and I don't know for sure if it's glaucoma or not, it's a good news. Because when I look for the first time a patient and I'm sure that's glaucoma, I got the feeling that I'm arriving late on this case. So being suspicious is good, and the patient is very anxious to have an answer. Do I have glaucoma? Do I not have glaucoma? I'm You're the 4 doctors that I'm seeing. The first one was telling bad things about the second one, and I just leave here if you tell me if it's glaucoma or not. So being suspicious is good. And nothing had changed in the visual field for this patient. But look for, this is very interesting, look for the progression analysis in the area that there was a glaucoma suspect. It was progressing in this area and everything else was flat. This is something interesting. Everything else was flat, but the superior temporal nerve fiber layer. So it makes sense. And here, looking for the density, this is the macular evaluation, is also a damage that is progressing in the same area. So it might be glaucoma and a glaucoma that you should treat. And now comparing the red free that I have, see, now I can see a double defect that had progressed. And the segmentation here, you're able to see that the area that I thought that might be a local defect actually is something happening here. It's progressing. And see the Don-Hood analysis. It gives what would happen with the visual field with the information that we have from OCT. What you expect to see in the visual field with the information that we have from OCT is also progressing. I have some fancy analysis on visual field that I'll just skip, showing that there's something happened also with the visual field. And looking back, that's a good thing about having the retinography is looking back in 2017, there's a small hemorrhage that I missed the first time that I saw the patient. So every time that you think there's a progression happening, take all the past exams that you have to make your mea culpa. Do you know mea culpa? It's Latin, everybody knows that. So maybe you're missing something. That's every progressive disease is much easier to see something if you do a longitudinal evaluation, and you can see in the past what you're missing by looking what's happening now. So for this patient, it was done selective trabeculoplasty. This case here, it's a very interesting one because I know for sure it's a glaucoma. It's a post-traumatic, blunt trauma glaucoma in the right eye. So there's a difference of IOP and a deficit in cup-disc ratio. And the OCT was clear abnormal. But when you look for, again, it's almost one of your examples of very clear damage in the macular area and nerve fiber layer area. So in this situation, this is a for sure diagnosis of glaucoma. And the visual field was normal and did not progress. I don't have the visual field itself, but it was normal and it was not progressing. But if you look again by the trend analysis and the probability map, the damage was there. Every time that you do the exam, the damage was there. The shape was like a local defect for glaucoma, and it was progressing. So everything was flat, but the region of interest. So you have to look if the segmentation is okay for each exam, if the sign is okay for each exam, and if it makes sense, and it was the case. For this one, this is a 10-2 exam for this patient showing almost normal visual field, 1 point in the upper segment of the visual field. This is microperimetry, 10-2 of microperimetry, and the down there is high density microperimetry in the region of interest, and it was normal. Why is that? Maybe it's because of the size of the stimulus. If I made a change in the size of the stimulus during the stimulus size 2 of Goldman, and now I see that I was able to see the defect. The thing is, sometimes the visual field is normal, but it doesn't mean that if you change the approach of the way you do the visual field, it will be always normal, it makes sense. Does it change anything that I'll do for this patient? No, I'll have to treat this patient is progressing. I don't need to do this kind of visual fields just for research proposals. And this is also interesting. Professor Don Hood has a cluster for visual field for 10-2 that you can see if it's progressing by cluster. And although the normal 10-2 was not progressing, if you work with cluster, it was progressing in one cluster, and specifically the cluster that was related to the damage of the OCT. So it makes sense. This is a point-wise regression analysis showing that was probably something's happened also with the visual field, although it's in the normal range. And I think this is the last one, just to show something that we can do with microperimetry, showing that what we see in the defect, remember, when you're working with a 10-2, outside the macula, you just have points 6 degrees apart. And for this patient, I use just a high density microperimetry showing that where the damage, you can see the damage in the OCT. You can see also on the microperimetry. Against the same patient, see that for the inferior one, it's very clear that the defect, we have a very deep scotoma, but at the upper one, you can see damage that we're not able to see in the 24-2. It's the same thing, just showing how nice it is to work with the unphased OCT and see if progression is happening or not, and work with high density perimetry. We are not using this anymore. We're just following the shape of the defect. It's now the way we're working with the microperimetry, but it was in the beginning, and the idea was to show even if the damage is increasing the size, we can do that. We can see that by cutting also with the specific stimulus with high density perimetry. Okay. So that's the case that we use to show that all the fancy stuff that we have for the OCT, you're able to do that in your clinical practice. And if you use that, probably gonna not miss cases that are progressing, and will be able to do correct diagnosis of the suspicious, follow the suspicious, seeing that if something is happening, and use all the tools that we have on OCT. That would help you a lot to follow our glaucoma patients. Thank you very much, and thank you, Top, for the opportunity.
Thank you, Augusto. As always, also a great presentation. Tenemos tiempo para unas preguntas. Si alguien tiene... sí, hay varias preguntas. Les van a pasar un micro ahorita y con gusto los doctores... Para mí la pregunta no.
¿Ah?
Para todos.
Una pregunta para el Dr. Hood. Cuando tengo el ENFACE, ¿listo? Cuando tengo el ENFACE de 52 micras y yo veo que es prácticamente normal, pero yo bajo y edito y bajo a 80 micras, veo defectos que a 52 micras no la veía. Les pregunto, ese 52 micras es un promedio, pero no podía ser mejor 80 micras, un ENFACE de 80 micras, porque siempre que encuentro que bajo 80 micras, encuentro el defecto mucho más fácil. Esa es mi pregunta.
Can you hear me? Yeah. So the question is about the en face and how do you select the thickness. Ideally, it would be interactive where you could adjust it and change it. I don't trust the en face by itself. I actually look at that last, and where it's most valuable is when you have very, very local defects, and if it's real, but up near 12 o'clock, right? But if you make that too thick, it might be harder to see this, right? So the way it works is you're averaging over a certain distance like this, right? So ideally, you'd want to be wherever the defect was. So if the defect was down here, you would not only want it to be thinner, but lower. If I'm making sense, this is a very advanced question. But the simple answer is no one thickness is going to be ideal. And I can't tell you whether 80 would pick up more. I can tell you I use that last, and I mainly use it to pick up these small defects that aren't obvious on the probability maps.
There's another question. ¿Tienes otra pregunta?
So this is for the panel. So if you have all that information of damage in the OCT, do you still wait to see damage in the visual field to make the diagnosis?
No, go ahead.
Okay. You want to just stop doing visual fields, is that correct? It's something that maybe in the future. The problem is that when we have perfect case here. We have some patients with retinal damage for other reasons. You have patients with high myopia. You have patients with every inflammatory membrane in the retina. Everything will change the exams and the progression. You're still going to need the visual fields for that. I think that but for some patients, for example, when you're just as a glaucoma suspect, a physiological cup that we were talking before, I performed the OCT before, and I only perform the visual field if it makes sense. Because I know that even if it's a glaucoma suspect, the visual field would be normal, and I think there's no reason for me to do every time, for every year, this glaucoma suspect that is more likely not have glaucoma to perform a lot of visual fields. I just follow them with the OCT.
Yeah, let me just reinforce those points. I'll take a non-controversial position at first and say, at the very least, if you understand the OCT, you'll be doing fewer visual fields. At the very least. And you just gave a good example of the healthy patient who happens to have a big disc and a family history, and you're killing that patient over and over again with visual fields, but they have never changed. Follow with an OCT, okay? The more controversial one is progression. So the visual field people have convinced everyone you need 5 tests or so to see progression, and that's because of the variability on the visual fields. You don't need 5 tests to see progression on the OCT, right? So I think as the OCT becomes better understood and you start following it like you were doing for progression, you'll be doing far fewer visual fields. Great question.
It was great. ¿Hay otra pregunta ahí?
Qué pena. Otra pregunta. Yo soy un enamorado del tritón, pero me pregunto, ¿por qué siendo tan bueno no hacen la eliminación del nervio óptico por la apertura de la lámina de Bruch? Porque en los pacientes con la atrofia peripapilar y miopes, el equipo se pierde completamente. Hay que bajar y editarlo. ¿Por qué no han dado ese paso hacia delimitar el nervio óptico con la apertura de la lámina de Bruch y lo siguen haciendo con el epitelio pigmentario?
I don't work for TopCon, and I'm not involved in that level of the software, but we can convey that question to other
Yeah.
people, unless you know the answer to it.
Yo sé que la apertura en membrana de Bruch es muy utilizada en muchos equipos. Se sigue trabajando con el epitelio pigmentario de la retina, que es donde normalmente vas a encontrar los límites para trazar el disco. En realidad, a no ser que tengas casos como lo que tú comentas, que sean altos miopes, patología muy marcada, donde puedas realmente encontrar el límite de la apertura de la membrana de Bruch, en la gran mayoría de los ojos sí logra encontrar la delimitación adecuada. Entiendo que es un punto bajo no trabajarlo exactamente a ese nivel, porque podría ayudarte muchísimo, sobre todo en los sospechosos, en los pacientes con miopías altas, con discos tildados o pacientes que normalmente no pueden hacer una delimitación adecuada. En realidad lo que están haciendo es orientarse más hacia el análisis topográfico de glaucoma. No quiero decir que no sean importantes los parámetros anatómicos de disco, pero con todo el resto de armas que tiene y la sensibilidad que tiene el OCT, sobre todo para hacer pinpoint de regiones de interés, de análisis a nivel de las células ganglionares o análisis a nivel de la capa de fibras nerviosas, creo que la gente encargada de R&D en la empresa está orientado más hacia los trabajos de Don, que tienen más que ver con el análisis de capa de fibras y análisis de células ganglionares. De todas maneras, es un punto que tenemos, que tú y yo lo hemos conversado bastante, y creo que es algo que podríamos evaluar, cambiarlo en el futuro cercano. ¿Tienen alguna otra pregunta?
Yeah, let me just add to that too. There are characteristic artifacts. We don't have time to go into them now, but that's a separate lecture. Some of them, one is when you don't have a centering of the disc. So you can recenter that, and there are other reasons why the centering will fail no matter where you use a reference, such as really bad epiretinal membranes and,
Yep.
and extreme tilt and so on. So you always want to be on the lookout for a centering artifact and then recenter, or have the technician recenter.
¿Tienen alguna otra pregunta? Bueno, creo que si no tienen ninguna otra pregunta, quisiera agradecer a todos por su asistencia. I would like to say thank you to you both guys. It's always a pleasure to be with you. Always you give great lectures, and it's for me an honor to present you both. Thank you very much. Gracias a todos.